Welcome to this video on benign and premalignant breast disease. We will cover definitions, common conditions, identification of high-risk lesions, and surveillance strategies. Let's begin with a case study of a 34-year-old female presenting with a palpable right breast mass. The clinical and imaging findings currently point to a BI-RADS5 classification, necessitating further evaluation. The mammography shows heterogeneously dense breast tissue with a large, encapsulated, circumscribed lesion in the right lower central region. The ultrasound confirms a large, well-defined, oval-shaped hypoechoic lesion with mild cystic changes, measuring approximately 6 by 3 centimeters. Our learning objectives for this video are to define and classify breast lesions, recognize common benign conditions, identify high-risk lesions, and guide appropriate surveillance and prevention. Core definitions distinguish between benign breast disease, a broad range of non-malignant conditions, and premalignant disease, which involves lesions that increase the risk of future carcinoma, such as ADH, ALH, or LCIS. Benign breast conditions are highly prevalent. Many clinical referrals ultimately result in these diagnoses, with fibrocystic changes and fibroadenomas being the most common entities encountered in practice. Managing these conditions is important to balance cancer detection with avoiding unnecessary interventions. We must use systematic pathways for differentiation and risk stratification. The DuPont and Page framework categorizes lesions by risk. Non-proliferative conditions carry no significant risk, while proliferative disease with atypia significantly increases the risk of developing future breast cancer. Clinical assessment is vital. We evaluate for palpable masses, mastalgia, nipple discharge, and inflammatory changes, always remaining vigilant for signs that mimic or mask malignancy. The triple assessment approach, combining clinical assessment, imaging, and tissue diagnosis, is the gold standard for investigating these symptoms, beginning with a comprehensive history and physical exam. Mastalgia, or breast pain, is the most common complaint. Management often focuses on supportive care, such as supportive bras, NSAIDs, and lifestyle adjustments, rather than surgery. Pathological nipple discharge is defined as spontaneous, unilateral, and from a single duct. It requires rigorous investigation with imaging, and, if a lesion is present, tissue biopsy. Fibrocystic change involves fibrosis and cyst formation. It is clinically characterized by nodularity and cyclical pain, but it generally does not increase breast cancer risk unless associated with atypia. Breast cysts are fluid-filled cavities. Management depends on symptoms and whether they are simple or complex, with ultrasound criteria helping to guide the need for further evaluation. Moving on to fibroadenomas, these are common fibroepithelial tumors seen most often in women between 15 and 35. They typically appear as firm, mobile, and well-circumscribed lumps, often described as, quote, breast mice. Fibroadenomas are hormone sensitive and are usually monitored through observation if imaging is stable. Excision is reserved for cases of diagnostic uncertainty, significant patient anxiety, or giant fibroadenomas over 5 centimeters. This imaging slide highlights the ultrasound appearance of a fibroadenoma, showing an oval, circumscribed lesion that is wider than it is tall, confirming its benign characteristics. Phyllodes tumors are rare, biphasic fibroepithelial lesions. Unlike fibroadenomas, they exhibit a characteristic leaf-like architecture. Peak incidence is between 40 and 50 years of age. Phyllodes tumors are classified by the WHO as benign, borderline, or malignant, based on cellularity and mitotic activity. The stromal component is key, as it determines the tumor's behavior and risk profile. Clinically, a phyllodes tumor often presents as a rapidly enlarging, painless mass. Surgeons must remember that these tumors metastasize primarily via hematogenous spread, meaning routine sentinel lymph node biopsy is generally not indicated. Here we see a summary comparing fibroadenomas and phyllodes tumors. Key differences in patient age, growth rate, and histological findings are essential for accurate clinical differentiation. Radial scars are intriguing because they are, quote, stellate mimics on imaging. They consist of a central fibroelastotic core with radiating ducts. While benign, they can look exactly like carcinoma, which is why surgeons remain cautious. Management of radial scars depends on the presence of atypia. If the lesion lacks atypia and there is good radiological pathological concordance, observation may be sufficient. However, if atypia is identified, surgical excision is typically recommended. Papillary neoplasms include a spectrum ranging from benign intraductal papillomas to papillary carcinoma. Patients often present with single duct bloody discharge, which is pathological until proven otherwise. For papillary neoplasms without atypia, close observation may be appropriate. If atypia is present, surgical excision is required to rule out an underlying malignancy within the ductal system. Atypical ductal hyperplasia, or ADH, is a high-risk lesion that resembles low-grade DCIS. Because it is a significant marker for future breast cancer and often coexists with occult malignancy, surgical excision is the standard management. Atypical lobular hyperplasia, or ALH, involves atypical cells within the terminal duct lobular unit. While it increases the relative risk for future cancer by 4 to 5 times, it generally has a lower upgrade risk than ADH. Lobular carcinoma in situ, or LCIS, is characterized by a discohesive proliferation of cells. Importantly, it is considered a marker of future bilateral breast cancer risk rather than a direct precursor like DCIS. Ductal carcinoma in situ, or DCIS, is a non-invasive malignancy confined to the ducts. Unlike LCIS, it is a direct precursor to invasive carcinoma and typically requires surgical excision and often radiotherapy. Let's turn our attention to evidence and contemporary practice. The gold standard for investigation remains the triple assessment. Furthermore, studies like those by Hartman et al. In the NEJM have quantified the significant risk increase associated with findings like ADH. This algorithm illustrates the diagnostic pathway for breast complaints. Starting with a clinical symptom, we proceed through the triple assessment. Depending on the pathological results and radiologic concordance, we may opt for simple observation or MDT discussion and potential excision. For high-risk lesions, management extends beyond surgery to include long-term strategies. These include chemoprevention using tamoxifen or aromatase inhibitors, enhanced surveillance programs featuring supplemental MRI, and in some cases, risk-reducing surgery. In summary, most breast complaints are benign. Always utilize triple assessment, recognize that atypia increases cancer risk, and carefully balance the need for surgical excision of ADH or surveillance of ALH and LCIS against the risk of overtreatment.